Ladies and gentlemen, please take your seats. If I could please have your attention for a few safety and housekeeping announcements. In the event of an emergency, please remain calm and walk, do not run, to the nearest exit. Emergency exits are located at the front left and rear left of the room. Please look around you and note the location of the exit nearest you. It is not the same way you entered. This program is being webcasted. To maintain quality of the feed, we need to limit movement in the room. However, if you need to use the restroom, there are two marked single-stall restrooms located in the entrance hallway near guest registration. Self-serve beverages are available in the back of the room. If you become thirsty during the program, please silence your cell phones now if you could, and thank you for your attention and cooperation. The program will begin momentarily.
Afternoon, everyone. My name is Kirk Johnson. I'm the director of the museum, the Sant director of the National Museum of Natural History. It's my pleasure to welcome you here to the next pandemic. Hopefully it's not actually the next pandemic right here. You might think a natural history museum is not a natural place to have something like this, but I would suggest that a natural history museum is probably the best place to have a meeting like this. This museum that you're in is the world's largest natural history museum. It has 145 million objects. And we say that objects, whatever, but the reality is that our species has been collecting the natural world for the last 300 years and preserving those objects in museums. And this is the place where we have what we know about planet Earth. So the records of collecting over the expansion of humans over the last 300 years, preserved and accessible to research scientists. At any given year, there's about 400 PhDs working behind the scenes, publishing 700 or 800 papers. Last year, over 400 new species were described by scientists working in the building. At the same time, every year we welcome about 6 million visitors. Most of those visitors are tourists, which means the next year it's a different 6 million, which means in a decade you might get as many as 50 million people in this building. World's largest collection, wrapped with scientists, visited by the world's largest visiting audience for public science education. And we live in interesting times with human population growing. There are so many things happening on the planet where humans interface with the natural world and where things like pandemics can emerge. Just a couple of examples. If you were to go in the other side of this building into the 6th floor, you'd walk into a collection that has 640,000 birds, skins collected over the last 300 years from all around the world. Other side of the building, 590,000 examples of mammals. So a huge collection of actual organisms that carry the genetic code of their species, but also carry other features of their environment. As they lived, they became biological data collectors. Recently, several thousand of these birds were sampled for evidence of the 1918 influenza pandemic, because we had birds that were collected around 1918. You can't go back to 1918 and recollect those birds. We have those birds. And we sampled 25 and 6 tested positive for the influenza. So we have in our collections effectively fossil examples of diseases. And when diseases break out, there are times when those outbreaks the actual vectors are not known, and a classic example is the hantavirus, which was discovered in a museum collection. So we've come to realize that our museum collections aren't just historical artifacts, they're actually research tools. In fact, they're scientific infrastructure that allow us to investigate emerging scientific issues in areas of emerging infectious diseases and food security, invasive species and pests, et cetera. So it's an interesting time to be in a museum, and I welcome you here today. We are going to be opening an exhibit next spring called Outbreak, Epidemics in a Connected World. And this really will map the museum perspective on disease, the fact that human health and environmental health and animal health is all related. We call it One Health. And the exhibit will discuss a lot of emerging infectious diseases and present them to this huge public. A couple of years ago, we did an exhibit called Genome, about the human genome discovery. And it was a great exhibit because most scientists have a pretty great understanding of what's happening in human genomics, but the general public has almost no clue what a genome is. And to take the tools of the museum and interpret something like genomics for the public provides a bridge between specialists and the world. And we'll do the same thing for emerging infectious diseases with the Outbreak exhibit. One of your speakers later today is Dr. Sabrina Schultz, who is the curator on staff here, who's the lead curator for the exhibit. So all that to be said, I'd like to introduce our first speaker, who's someone who I just met a moment ago, but I really enjoyed his work over the years. John Barry is a best-selling author and historian. He's currently a distinguished scholar at Tulane University, where he's focused very much on the fate of the Gulf Coast. I came to know him from his book, Rising Tide, the Great Mississippi Flood of 1927, and how it changed America. He's also written a book entitled The Great Influenza, the story of the deadliest pandemic in history, published in 2004. The Great Influenza was ranked by the National Academies of Sciences as that year's outstanding book on science and medicine. He was the only non-scientist on a federal infectious disease board of experts. And he was on the team that developed non-pharmaceutical interventions to mitigate a pandemic. He's also advised both the Bush and Obama White House on pandemic preparedness. So with that, I'd like you to help me welcome John Barry to the podium.
Thank you, and thanks for coming, and thanks for putting together this conference. I want to give you a very quick summary of what happened in 1918 and what we might learn from it. The estimates of the death toll start at 35 million and go to 100 million. Adjusted for population, that would be approximately 150 million to 400 million today. Most of the dead were adults aged 20 to 50. Probably about between 3 to 8% of the entire population of people in those age groups died. In certain subgroups, it was worse than that. There were numerous studies of pregnant women that had case mortality rates from 23% to 71%. In virgin populations, it was not unusual for 20 to 30% of the entire population to die. And although the focus has often been on the young adults who died, they are not the only people who died. Look at children. Even in the West, where case mortality was the lowest, the 1918 pandemic killed as many children aged 1 to 4 as today die of all causes over a 20-year period. It killed as many children aged 5 to 14 as die from all causes over a 10 to 15-year period. And remember that well over half the deaths occurred in a period of weeks, about 10 weeks in the fall of 1918. So just think of the impact that would have. Today, even a non-lethal pandemic could sicken between 60 and 100 million Americans, 2 billion people worldwide. That would overwhelm the medical system, use up antibiotic stocks for secondary infections, destroy the timing of just-in-time inventories, devastate the economies. So we need to extract every lesson we can from 1918. And the first lesson is we need to put a lot more resources into vaccine research, particularly universal vaccine, but in the interim, improving technologies on vaccine manufacture. Second, to inform policy choices, we need to continue to study events therein. The virus itself, we continue to learn more about it, particularly Jeff Taubenberger, one of your speakers. It's epidemiology. Cecile Vaboud is certainly an expert there, another speaker. And we also need to look at it from an interdisciplinary perspective. I believe there is plenty to learn from 1918 still. I'll give you 3 examples of untouched data. I know of studies of several 100,000 people in institutions that relates directly to the effectiveness of hand washing. That data has not been touched. There is excellent data on quarantine by a brilliant pioneer epidemiologist strongly, not just suggesting, I think proving that quarantine is pretty useless in influenza. That's untouched. Maybe most important, I think there's data from the 1889 pandemic and from 1918 and from a recrudescence in 1920 about the first person in a household to become sick with the disease. I think that would certainly deepen and might challenge some of our understanding of how the disease spreads. But to me, the main lessons involve what today we call risk communication, which happens to be a phrase I despise because it implies managing the truth. And I don't think you manage the truth. I think you tell the truth. In 1918, chiefly because of the war, but not entirely for that reason, they did not tell the truth, or close to it. The disease was known as Spanish flu, yet national public health leaders called it, quote, ordinary influenza by another name. The Surgeon General of the United States said, quote, you have nothing to fear if ordinary precautions are taken. And what was true nationally was also true locally. The false reassurances were almost everywhere. At Camp Pike, Arkansas, a doctor reported his hospital closed, overwhelmed, doctors and nurses dead, thousands of soldiers sick and dying in barracks, and miles of double rows of cots. He says, everywhere there is only death and destruction. 7 miles away in Little Rock, the newspaper reported, Spanish flu is plain the grip, same old fever and chills. Now, I think society is built on trust. And these false reassurances, these efforts to keep morale up, quickly led to a loss of trust in authority. It was alienating, deracinating, isolating, and as a result, society began to disintegrate. As one person said, the disease kept people apart. You had no school life, no church life. It completely destroyed all family and community life. People were afraid to kiss one another. They were afraid to eat with one another. It destroyed those contacts and destroyed the intimacy that existed amongst people. In Philadelphia, there was a doctor who lived 12 miles from his hospital. There were so few cars on the road as he went home every day, he started counting them. One day, on a drive of 12 miles, there was not a single other car on the road. He said the life of the city has almost stopped. On the other side of the world in New Zealand, another doctor stepped outside of his hospital and said, I stood in the middle of Wellington City at 2 o'clock on a weekday afternoon, and there was not a soul to be seen. It was a city of the dead. There were people starving to death, not because there wasn't food, but because people were afraid to deliver food to them. Victor Vaughn, who had been the dean of the University of Michigan Medical School, a serious, sober person, not given to overstatement, said, if the present rate of acceleration continues for a few more weeks, civilization could disappear from the face of the earth. That's what happens when people lose trust in each other and in authority. And to test my hypothesis, or the hypothesis, that the truth does make a difference, there was one city that did tell the truth, and it was an entirely different experience. In San Francisco, the mayor, the city council, labor leaders, business leaders all put their names on a full-page ad, huge print, said, wear a mask and save your life. Now, the mask didn't do a damn bit of good, but that is a very different message than this is ordinary influenza by another name. And in San Francisco, the city was extremely well organized. Certainly nobody starved to death. Blocks were well organized. Teachers, when schools closed, they volunteered as orderlies, telephone operators, delivering things. The San Francisco paper said, one of the most thrilling episodes in the city's history was the story of how gallantly the city behaved during the epidemic. That's what happens when you do tell the truth. So I think the lesson is clear. Public compliance with recommendations will be difficult under any circumstances. Sustained compliance will be much more difficult. In Mexico City in 2009, for example, Masks were recommended on public transit, free ones distributed. Usage peaked at 65%, and 4 days later, it was down to 27%. So if we expect compliance with recommendations, authorities need to get out front and stay out front. They need to be totally accessible. They need to stay ahead of internet rumors. And the final lesson is not from 1918, it's from 2009. Planning does not equal preparation. There was a lot of planning done between 2004 and 2009, but when that very mild pandemic hit, it was as if, at least by authority figures, none of that made any difference. You look at irrational responses in China, Egypt, India, Britain, France, even some, to a lesser extent, the United States. And again, planning does not equal preparation, which means I think maybe the biggest challenge to the public health community is to get political leaders to make rational decisions in crisis situations. And that is where leadership in the public health community really matters. Thank you.
Good afternoon. I'm Michael Caruso. I'm the editor-in-chief of Smithsonian Magazine, the magazine that, not coincidentally, you've all seen on your chairs. If you like what's in there, we did 3 stories in this issue, all about influenza. If you like what's in there, it's due to the efforts of Terry Monmany, our deputy editor, and Jenny Rothenberg-Gritz, who's here, our senior editor. If you don't like what's in there, it's my fault. I have one of those impossible roles here, introducing a man who needs no introduction, especially to the people in this room, but I'm going to plow on anyway. So bear with me. When it comes to thinking about epidemics, everybody wants to talk to Tony Fauci. He's been America's point man on infectious disease for 33 years now. He's led our nation through every infectious disease crisis through those years, from AIDS to Ebola to Zika. Dr. Fauci is a member of the National Academy of Sciences. He has 42 honorary doctoral degrees. He's received the Presidential Medal of Freedom, and his citation reads that it is for his commitment to enabling men, women, and children to live longer, healthier lives. With his broad appreciation for the public good and his nonpartisan nerves of steel, Dr. Fauci oversees a $4.9 billion annual budget. The stories in our new issue of Smithsonian Magazine and this event itself grew out of an answer that Dr. Fauci gave us that was posed to him on stage at another event of ours a couple years ago. We asked him, "What concerns you most? What keeps you up at night?" And his answer was simple, 2 words: pandemic influenza. Okay, we thought, let's hear more about that. Ladies and gentlemen, Dr. Anthony Fauci.
Thank you very much for that kind introduction. So following that encouraging story from John, I'm going to tell you a little bit about the next step that I think John was very clearly referring to about what we need to do regarding preparation. And that's what I'm going to talk about in my 10 minutes, namely preparing for the future in pandemic influenza. So the first thing that I want to do is to make the point that when you look at influenza, the preparation for seasonal influenza essentially should be the preparation for pandemic influenza in a perfect world. And the perfect world that I hope we get to within the next period of years, we certainly are trying hard for that, is the development of what John alluded to is a universal influenza vaccine. And let me tell you why, as someone who's an infectious disease person, that I am concerned about our capabilities today against any kind of influenza. So I want to break it up into 3 quick parts. First of all, the current seasonal influenza vaccines are not consistently effective, and that's a fact that we just have to face. If you look at from 2004 until the last year, when you have a bad year with a mismatch, as we saw in 2004-05, you have a 10% efficacy. At best, as we had in 2010-11, you have a 60% efficacy. Compare that to other infections that we have vaccines for. Measles vaccine is 98.5% effective. Yellow fever is 99% effective. Polio is more than 90% effective. Now, there are a lot of reasons for that. We all know about the drifts. We all know about the mutations. We all know about the fact that the response against the hemagglutinin, although it can be very effective, drifts from year to year and sometimes shifts. But this is the stark reality of how we address seasonal influenza. Now, pandemics do occur. You just heard from John about the mother of all pandemics, but we've had 3 since then, in 1957, 1968, and the most recently in 2009. However, the response after the fact is not effective. Now, John alluded to the 2009 H1n1 pandemic, in which we actually had a bit of warning. And I want to show you what the response was of those of us who were going as quickly as we possibly could. So it was the swine flu. The first thing is that we were expecting, as we always have, that the next pandemic would come out of China or the Far East, when in fact it did not. It came right in our Western Hemisphere, somewhere around California and Mexico. Now, you recall, and I'm sure people in this audience do recall, that at the end of the 2008-09 season, as things were coming down in March, the way they do, it usually peaks in January, all of a sudden, in March and April, we started to see a new kind of influenza. And so we felt, let's make a vaccine for that influenza. And this is March. This is what happened in April, so it wasn't a 1976 shoot from the hip and get into trouble as we did then by vaccinating everybody when we never got the epidemic. We knew we were going to get a pandemic. So in April, this is a picture of my good friend Ann Schuckert and I testifying before our Appropriations Committee in April, saying, and you could go back and see what we said, is that it's April. It takes about 6 months to get a vaccine going. So if we start working now, May, June, July, August, September, October. If we have the vaccine by October, then we'll be prepared for the inevitable pandemic. However, what happened? The children came back to school, and instead of having an epidemic or a pandemic that peaks in January and February, it peaked in September, as graphically shown on this slide. So what's wrong with this slide? The blue line is where the red line should be, and the red line is where the blue line should be. In other words, the percent of illnesses peaked before we had the vaccine available, which became available. It would have been wonderful if it had a peak in January, but it didn't. It peaked in September. So even though we have some warning about a pandemic, even then, with our current capabilities, it doesn't work well. This is a picture. Notice the expression on Tom Frieden and and Jesse Goodman explaining to the House Oversight Committee about the vaccine that we were supposed to have in time. We didn't. And then there's the third thing, and that is chasing after potential pandemic outbreaks. I refer, and others refer to them as pre-pandemics. It is costly and it is ineffective. And let me just give you a couple of examples. You all recall the H5n1, the chicken virus that started in Hong Kong, jumped species, had a high degree of mortality, but didn't develop the capability of going efficiently from human to human. We took this very seriously. And what happened? It was during the George W. Bush administration. He asked for over $7 billion, and we spent about $4 or $5 billion to switch from eggs to cells, which I don't think is a very major advance, as we'll get to in a second. But we made a vaccine, we put it in the stockpile, and nothing happened. But we did do something really good. We put a pandemic influenza preparedness plan involving what you see on this slide. We approved the vaccine that we had. The first adjuvanted H5n1 is available, stockpile. We didn't use it. Then what happened is several years later, we had the H1n1, same thing. Chicken virus jumps from chicken to humans, high degree of mortality, not efficient from human to human. It started in 2013. We were quick. We made a vaccine in 2013. We stockpiled it. There was a mini outbreak in China in 14, 15, 16, and then what happened in 17? It mutated a little, and the virus and the vaccine that we had for the 2013 strain was not protected by the vaccine that we developed for 2017. So we had to go back again and start all over again. What is this telling us? This is telling us my conclusion, that we need to get a universal influenza vaccine. It's going to be incremental, it's going to be iterative, but I think from a scientific standpoint, we will get there. Well, we will if I get this. Okay, just very brief for about 30 seconds. There are a number of ways to get a response that is universal against all viruses. One of them, not the only one, and I want to emphasize, is that when you look at the hemagglutinin in the head and the stem region, it's very clear that sorry, this is not working well. Can we go back one? Okay. There you go. So I'm sure people in the audience are very well aware of that the part that is protective in the current vaccines is the head of the hemagglutinin. That's the good news. The sobering news is that that's the part that mutates or drifts from season to season or shifts when you get a pandemic. To make a vaccine with a response against the conserved regions in the stem is one of the ways that we are pursuing, and a variety of others are pursuing, to try and get a vaccine response that is against virtually all strains. So I want to close on this slide. We had just written this for Scientific America, and it's somewhat of a pessimistic statement, but I use it not for pessimism, but to spur us on to the goal of what we need to do, because 100 years after the lethal 1918 flu that John just described, we are still vulnerable, and our public health infrastructure has improved greatly, but without a universal vaccine, a single virus would result in a world catastrophe. Thank you.
Well, thanks very much to John and Tony for those presentations that nicely set up our first discussion panel, which will focus on what scientists have learned about the 1918 influenza pandemic and how that knowledge is helping in the development of intervention strategies aimed to prevent or minimize the emergence of a new pathogen. I'm Andrew Pekosh from the Molecular Microbiology and Immunology Department at Johns Hopkins Bloomberg School of Public Health, and I'm moderating this first panel. I'd like to introduce our panelists. To my immediate left is Jeffery Taubenberger, Chief of the Viral Pathogenesis and Evolution Section and Deputy Chief of the Laboratory of Infectious Diseases at the National Institutes of Allergy and Infectious Diseases. His laboratory sequenced the 1918 influenza virus, and he's been investigating influenza disease and pathogenesis in clinical studies in animal models using both seasonal and pandemic influenza viruses. Recently, he's been focusing also on development of universal influenza vaccines. In the center of our panel is Cécile Vibaud, who's an epidemiologist in the Division of International Epidemiology and Population Studies of the Fogarty International Center at the NIH. Her research focuses on the epidemiology and transmission dynamics of influenza and other respiratory viruses. And at the end of our panel is David Vaughan, who leads the influenza vaccine development at GSK Vaccines and supports GSK efforts to develop rapid response vaccine platforms that can be used to generate vaccines against influenza or any number of potential human pathogens. All right, I'm going to take my place here at the counter. We'll be more than happy to take questions from the group, but before we do that, I just wanted to start with a few questions to the panelists to introduce you to some of the work that they're doing and have them explain some of the important work that they've been focusing on recently. So, Jeff, your lab led the efforts to determine the sequence of the 1918 influenza virus and subsequently to investigate why the virus caused such massive amounts of disease in humans. Could you tell us a little bit about what your efforts to sequence, rescue, and characterize that virus told us about that specific strain and how it maybe mediated some of the incredible pathogenesis and disease that we saw in during that outbreak?
Sure. So the influenza was known as a clinical disease in 1918, but influenza viruses were not yet known and recognized. The thought at the time was that influenza was caused by a bacterial agent, although that idea was already waning in 1918. So unfortunately, by the time the pandemic came and went, there were no opportunities to isolate the causative agent. So 20 years ago, in my lab, we used kind of a molecular archaeology approach to try to sequence the virus from tiny fragments of the genome of the virus still present in fixed preserved autopsy tissues of people who died, unfortunately, in the pandemic. So the effort to do that was difficult back then, especially due to the technology available. But the reason for doing that was to try to understand some of these questions of where did this virus come from, why did it cause so much disease, and why did it affect people in a way that's different from other pandemics. And a lot of these questions are still not completely answered, but we have learned a lot of information. But I think the most important thing that I would share in the couple minutes that we have here is that the features that made the 1918 virus as virulent as it were do not seem to be specific to that pandemic. They weren't mutations just in that virus. They're features that are shared with other circulating influenza viruses, especially those in birds, and share some of those behavioral features with some of the pre-pandemic viruses like H7 that Dr. Fauci alluded to. So I think the most important thing is not to just understand 1918 as a historical phenomenon, but as an example of what could happen in the future, and to use this information to help us gear for how to prepare, predict how bird viruses could adapt to humans, what mutations would correlate with this kind of high virulence, and then ultimately what we could do to prevent it.
Thanks. Cecile, so as an epidemiologist, you spent significant effort in studying how pathogens like 1918 influenza spread in the human population. Could you tell us about what your investigations into this pandemic has taught us about the spread of 1918 influenza in the human population, and whether it was really different from what we've seen with other pandemics or in fact what we see with seasonal influenza?
Yeah, so I think what made this pandemic really unique was the severity of it, and it's been commented by the previous speaker. But we've now looked at historical epidemiological data from countries around the world, some involved in World War I, some not. And we see the severity, the mortality rate was unusual and about tenfold higher than when we've seen for epidemics surrounding that period. So it's not just because people didn't have access to treatment. It was just something really unique about this strain and this population that was hit by the strain. The other distinctive feature is the age pattern of death, or the fraction of the population at highest risk of mortality. And we see this very unique peak of mortality at around age 28 years of age all around the world. And that's very difficult to explain. We think it's a combination of increased severity in young age group and protection in older age group that had seen some of a related strain earlier on in childhood. But exactly the mechanisms that are involved are pretty unclear. And that's very unique to this pandemic. We've also now looked at historical pandemics from 1889 to 1918, 1957, and 68, 2009, and they're all different. They're all a little different, right? They share features. They come at odd times. They come in the summer. They come in autumn, and they affect more of the younger population. But they're all quite different, and so that means that for the future, we just need to have systems that are in place to have real-time epidemiological information on what this pandemic will look like. Will it be more like 1918 or 57 or 2009?
Okay. David, so in 1918 there were no pharmaceutical injections available at all to help stem the pandemic. We now have both antivirals and vaccines, though, as Tony mentioned, their efficacy is not as high as we'd like them to be. Could you talk a little bit about influenza vaccine history and where you see the field going sort of in the near future to try to improve those tools that we have to deal with the pandemic?
Yeah, sure. I think back in 1918, as Jeff just pointed out, they were already working on vaccines, mistakenly working on a vaccine for a bacteria, Haemophilus influenzae. It wasn't until 1931 that it was definitively shown that influenza was caused by a virus. 1933, we were able to grow it in the laboratory. And by 1945, there was the first licensed vaccine in the United States. So there have been some improvements since 1945. There have been improvements in the manufacturing process. The 1945 vaccine was a bivalent vaccine for one influenza type A component and one influenza type B component. We're now moving to 4-valent vaccines. In 1945, we used embryonated hen eggs to grow the virus. Now, we still use hen eggs to grow the virus for most of our vaccines. But as Dr. Fauci pointed out, some companies are moving to cell culture to grow the virus, and some are largely bypassing the growth of the virus in a sense, in that they're using recombinant technology to express the proteins from the surface of the virus to make the vaccine. We have improved vaccines for older adults by virtue of higher doses or by using adjuvants. And I think importantly, we're using the vaccines more. Since 2010, there's been a recommendation for universal use of the vaccine for all of us from 6 months of age and older to get it each year. Still, as Dr. Fauci pointed out, our current vaccines need some work. There's much more that we can do. And they're different from other vaccines. First of all, the disease we're trying to prevent is very prevalent. Up to 20% of us will have an influenza infection during the course of a year. Secondly, the viruses keep changing. That's why we need a new vaccine each year. And also, the efficacy is lower than for other vaccines. But on Dr. Fauci's slide that showed the different efficacy estimates, 2014, 2015, the efficacy was just 19%. But CDC tells us that year that vaccine prevented 1.6 million cases of influenza despite relatively low use of the vaccine and a low efficacy. So increased use, particularly in pregnant women. We heard from John Barry about pregnant women being a particularly susceptible group for severe disease. So this all helps. Looking forward, I think there's at least 2 ways we're moving to improve things. Dr. Fauci covered the idea of universal influenza vaccines. If we're successful there, then we have a vaccine for any influenza virus, past, present, or future, human, swine-derived, avian-derived, we're set. And this is the kind of vaccine that WHO is looking for developing countries. Most influenza deaths occur in developing countries, and very few vaccinations occur there. The second approach is to advance these new rapid response platforms. GSK has a few such platforms. One of them, for example, was used to make a vaccine for H1n1 virus. It took 8 days to make that vaccine from the time the Chinese posted the sequence information for the virus until it was injected into cell culture and into mice. And in talking to the scientists that did that work, they tell me they could have done it in 4 days because there were 2 snail mail steps in the process. So, I mean, once we have these sorts of platforms that are working, it then becomes quality control, release of product, and the regulatory steps that are on the critical path. So I think there's much to look forward to. We just need the time and resources to make it happen.
So I'll encourage anyone in the audience to ask questions. If you have a question, just raise your hand, try to get my attention, and we'll try to acknowledge you and get you involved in the discussion. While we're waiting for that, though, a couple of follow-up questions. So maybe we'll start with Jeff. So let me put you on the spot. Do you think influenza is the most likely virus to cause the next pandemic, or are there other microorganisms out there that pose an equal or a greater threat to the human population?
Well, I think the future for influenza pandemics is always a good, strong bet for what a pandemic would be. There are certainly other viruses that we would think about. There are some other respiratory viruses in animals. For example, the family of viruses that led to SARS and MERS, something that's concerning. There are sort of paramyxovirus, measles-like viruses like Nipah and Hendra that certainly could be concerning. There are arboviruses, of course. We've had the insect-borne viruses like Zika that are concerning. But I think that influenza really is always the way to bet of something that's the most concerning. You have an enormous diversity of influenza viruses in an incredible number of animal species, both birds and mammals, in wild birds, wild mammals, and in domestic birds and mammals. And these viruses mutate like mad and can adapt and move between species in a really unpredictable way. And so that is what I think gives us the greatest fear, is that despite 100 years of studying the virus, we really have no way to accurately predict what strains will emerge, how they will adapt from one animal to another, and how virulent they will be. And that's the huge challenge.
Yeah, and I think to add to that, I think influenza and its natural vectors is such a very different disease. Doesn't really cause that much illness. These animals can be infected, shed virus for long periods of time, and go on migration patterns that take them hundreds, if not thousands of miles away to be introduced into new reservoirs. So I think the diversity out there and how those viruses move around the world is really mind-boggling. Yeah. All right, well, Cecile, so you've been doing a lot of work on understanding and modeling how pathogens spread in human populations. So this has been particularly fascinating to me as my center is working towards looking at understanding seasonal influenza more carefully. Could you speak to how modeling efforts can perhaps inform our public health responses to the next pandemic and sort of help us come up with interventions or ways to at least minimize spread of viruses?
Yeah, so I think modeling is very useful to run what-if scenarios. So, for instance, if in the context of a new pandemic, you have the option of closing schools, when should you close schools, for how long, and that might gain you time until a new vaccine becomes available. And models are very powerful to do that. There was also a lot of questions around closing borders in the context of a pandemic. And all of the models agree that it's no use to close borders. The disease is just too fast. So they're very useful for that, and there's more and more effort to embed modeling teams within the policy context. And that's been done for 2009, for the Ebola outbreak, for SARS, etc. There's also a really active area of modeling around forecasting, and there we are really decades ahead of the weather forecast, but we're really beginning and putting a lot of effort into that, from short-term projections of the outbreak trajectory and how high is the peak going to be every season, to projection of 3 to 6 months ahead of which strain is going to become dominant. And I think that it's going to progress, and that's quite exciting.
And then David, so you mentioned briefly in your answer to the first question, so GSK has started some initiatives recently really aimed at shortening in time to generate new vaccines to emerging pathogens, including ones with global pandemic potential. There's a relatively new facility opening up nearby here in Rockville, Maryland, devoted to those efforts. Can you maybe tell us a little bit about how that company is sort of approaching this idea of making vaccines to pandemics or potential pandemic organisms?
Yeah, GSK has been working with the U.S. government, specifically the Biomedical Advanced Research and Development Authority, or BARDA, since BARDA's inception in 2006, to develop and to produce preparedness products. So in our case, that's H5n1 vaccine, H7n9 vaccine. We have monoclonal antibody for anthrax, Influenza for treatment for influenza, and also antimicrobial resistance, which would be a great topic for another Johns Hopkins Smithsonian symposium. BARDA obviously is working with other companies, and I understand that to date they have 21 products in the strategic national stockpile ready for use. This is great, but it's not really sustainable. We need more and more products, and the products we have reach the end of their shelf life and need to be replaced. So GSK and others are interested to move more to the rapid response platforms. GSK was partially motivated by the 2014 epidemic of Ebola in West Africa. We responded to that outbreak with our primary scientific partners at NIH, and went from the start of a phase 1 clinical trial to the start of a phase 3 clinical trial in 5 months, rather than the usual 5 years or even longer. But it was too late. And so we need to be able to react faster. So again, GSK, many other groups are working towards these platforms. In the ideal, we would continue to have or even improve our surveillance. We'd identify a pandemic threat. It would be sequenced, posted to the cloud. Research laboratories would download it, create a vaccine, mainly in a computer, identify the gene segments that are needed for that, load it back up to the cloud, and then it would come down to different manufacturing facilities that are using that platform, using it every day for a standard vaccine, say influenza, many parts of the world. But then when the pandemic threatens, they interrupt their routine manufacture, start making pandemic vaccine, and within weeks and months, we have millions or billions of doses. That's the ideal. I glossed considerably there, but I think those are sort of things we can hope to look forward to.
No, I think that's an excellent point to make. I know that some of the work that we've been doing using seasonal influenza virus as the model system for trying to set up those kind of real-time diagnostic efforts, sequencing efforts, identify these pathogens, spread the word around, see what new variants are coming through. Again, seasonal influenza is a great way to model what you would want to do eventually in a pandemic. And so I think some of those efforts that you're talking about are probably not that far away.
At least for organisms where we understand it well, like influenza,
Yeah.
we know what the target should be in terms of the head of the surface proteins.
Yeah. Do we have a question? Yeah.
I know a lot of talk about vaccine. Obviously, that's the most important thing. But what about progress on antivirals?
So I'll repeat the question. So John asked that we've been talking a little bit about vaccines, but what about progress on antivirals and potentially their role in terms of a tool in countering pandemics? Do you want to take the...
There are antivirals against influenza, but really only in 2 classes. And the problem is that influenza viruses can very often develop mutations to make them resistant to these drugs. And so clearly, more classes, newer classes of drugs need to be made. Clearly, there has been a lot of research, both government-funded research as well as an industry, to try to develop new antiviral targets with flu. But as far as I know, I don't know how close those are to licensure. So we still are faced with that. Really, for many strains, the antivirals that are available for a physician to prescribe to a patient are often inadequate because the viruses are already resistant.
Nothing to add except the silver lining to the 2009 pandemic. The 2008 and earlier viruses were beginning to become resistant to oseltamivir, but the new H1n1 is susceptible.
Yeah, I do think that there's an added realization now that developing one antiviral is great. Having 2 or 3 and then administered as a cocktail is probably the ideal situation. Because again, in those situations, as you've seen with HIV and with hepatitis C virus, when you have a cocktail of antivirals, then the likelihood of resistance coming up really is decreased exponentially. And so I think that's something to keep an eye on in the future in terms of these developments. Yes, there are a few. I know there are a few drugs in the pipeline, and I know that there's been one new antiviral drug that's been licensed in Japan, but certainly I don't think that there is as many antivirals in the pipeline of development as there probably could be or should be. So, right over there. Yep, question.
Yeah, my question's for David. I'm wondering about the state of the science regarding the immune response mechanism for protection against influenza viruses. Tony Fauci mentioned antibodies against hemagglutinin. However, I went to a session in the medical center where his scientists showed a better correlation with antibodies to neuraminidase than to hemagglutinin with protection in a human challenge study. Fairly small study, but I found that a really interesting finding. It's just a fairly recent, few years ago. I'm wondering whether that's been pursued or whether what I was once told by Gordon Ada, that it's all about CTLs. Well, you know, there are always people that believe in CTLs. I don't really have a feeling for how much is known at this point about what kind of immune response would confer better than, let's say, the maximum 60%, which would not pass muster these days for approval of any vaccine? Thanks.
Well, I'm not sure I can, well, I'm sure I cannot completely answer that question. I don't know that much more than what you've stated in your question. There remain a number of unknowns about influenza and the best way to prevent it. It's complicated with having a series of infection that really complicates, so the history is important in terms of how you, as an individual, respond to a vaccine. There are different parts of the viruses, yes, that can be targeted by different means, through antibody, through cellular responses. Antibodies to neuraminidase will protect if there's enough of them, but the current standard, for better or worse, is hemagglutination antibody, which is acknowledged as perhaps meaningful by regulatory authorities. Would you like to add?
And I can speak to the fact that I spent the morning at a meeting at the NIH campus where universal flu vaccines were being discussed, and one of the first things that came up was to set up studies to better understand immune responses to infection and vaccination outside of the typical anti-HA antibodies, and to really get a stronger sense of what the natural course of an infection induces in terms of protecting antibody responses, and to no longer sort of fit into that, let's look for titers against the HA protein as our one gold standards. So I do think there's a much broader sort of thinking now that we need to go back, think about NA antibodies, T-cell responses, and the immune response in total to seasonal influenza, and use that as a way to help us inform universal flu vaccine studies going forward.
Yeah. We had it at that meeting that you're referring to. It became very clear that, because we had had some success with the seasonal flu vaccines, that we were okay, and there wasn't a lot of going back to the basics. And it's almost a little bit embarrassing that we have hemagglutination inhibition assays, we have microneuts, and that's what we use as the correlates of protection. When in fact, we haven't pursued neuraminidase as much as we should. We haven't pursued cytolytic T cells as much as we should. So if we're going to get to the universal vaccine that I was referring to, we're almost in some respects have to going to go back to the basics and ask fundamental questions of what the true correlates of immunity and what the scope of the correlates of immunity are. And it's very interesting that in 2017, we really don't know as much as we probably should. And that was the conclusion of that workshop that you were at.
Yeah, absolutely. All right. With that, I'm going to close this panel. I want to thank my, my panelists for the wonderful discussion that we had. And thank you very much for your attention.
Good afternoon, everyone. My name is Paul Spiegel, and I'm the director of the Center for Humanitarian Health at Johns Hopkins Bloomberg School of Public Health. So we're going to now talk about preparing for the worst and is the world ready to respond? And I'm hoping we're going to get, obviously, beyond the vaccine to other areas. Clearly, there won't be a universal vaccine anytime soon, and there's going to be a lot of people that are sick, and how will the healthcare systems in different countries respond? So we have two speakers, and I'm going to introduce the first one, Dr. Daniel Sosin, who is the Deputy Director and Chief Medical Officer of the Public Health Preparedness and Response, or PHPR, at the Centers for Disease Control and Prevention. And in this role, he is the lead science advisor and provides scientific representation for preparedness on behalf of PHPR and CDC. He serves as a liaison to the CDC programs and external partners and assures strategy and program coordination for PHPR in the medical and public health and preparedness response. So Daniel, welcome.
Thank you, Paul. It's an honor to be here and to represent the CDC scientists and staff who for more than 60 years have worked to address this threat of influenza and to improve the ways that public health responds to health crises. You have heard how the 1918 influenza pandemic was an unprecedented public health crisis, and nearly 100 years later, the world has made major advances in the science of influenza prevention and control. Influenza viruses, however, as you have heard, continue to pose one of the world's greatest infectious disease challenges, and the risk of pandemic influenza remains. Our vulnerabilities in a pandemic relate to the virus, the susceptibility of our population, and the environmental factors that favor the spread of disease. By definition, a pandemic virus is one for which the population lacks immunity and is capable of transmission from person to person and to cause severe disease. In addition to our naive immune systems in a pandemic, significant numbers of people today are more susceptible to severe infectious diseases because of diseases they have or therapies they take that compromise their immune system. The exponential growth of our populations around the world, expanded international travel, and increased proximity to humans to animal reservoirs increase the risk that a pandemic influenza will emerge with extreme effects. In the absence of a vaccine that can eliminate influenza pandemics, time will be of the essence, and early recognition of person-to-person transmission of a pandemic virus can make all the difference to an effective response. This is why ongoing surveillance networks around the world are so important. Many pathogens can cause similar symptoms to influenza, so diagnostic tests that are rapid, accurate, and feasible for widespread use are critical to rapid understanding of the pandemic conditions and for specific treatment plans. Non-pharmaceutical interventions, such as personal protective equipment, respiratory etiquette, hand hygiene, social distancing, can prevent disease transmission even when a specific medical intervention is not available. Vaccines, of course, will be an important part of the response even today. Medical treatments for influenza and secondary infections can save lives if available in the right hands at the right time. An effective pandemic response also requires effective communication with the public and with our health responders so that there is confidence in our recommendations and motivation to follow them. In 1918, we were sorely lacking in these capabilities. There was no national system of surveillance, much less a global surveillance effort. Viruses, as you've heard, have not been discovered, and there were no laboratory tests. There was limited personal protective equipment. There was no vaccine. There were no antibiotics to treat secondary bacterial infections and no antiviral drugs. There was no mechanical ventilation or intensive care units. We heard earlier about communication challenges in 1918, which are surely different today with respect to our understanding of effective communication and the variety of tools to share information. So what does CDC do to lessen the threat of influenza? CDC works with domestic and global public health partners to monitor both human and animal influenza viruses to know what and where viruses are spreading and what kind of illness they are causing. CDC supports more than 50 countries to build surveillance and laboratory capacity to find emerging influenza threats and to respond to them. CDC studies more than 6,000 human and animal influenza viruses in the laboratory each year to better understand the characteristics of these viruses. CDC develops and distributes tests and supplies materials to laboratories around the world so they can detect and characterize influenza viruses. CDC works with state and local government, the World Health Organization, and partner countries in pandemic planning efforts. CDC evaluates the effectiveness of pharmaceutical and non-pharmaceutical interventions and updates recommendations on these. CDC helps global and domestic experts choose which viruses to include in seasonal vaccines and guides prioritization of pandemic vaccine development. CDC develops candidate vaccine viruses used by manufacturers to make flu vaccines. And CDC monitors influenza vaccine distribution. CDC also manages the U.S. Strategic National Stockpile and supports public health departments across the country to ensure that critical medical supplies are available when and where they are needed. CDC also informs healthcare providers and the public about influenza prevention and control measures. And CDC works at home and abroad to train staff and establish emergency operation centers that improve the efficiency and interconnectedness of the public health response. Each emergence of a new virus, such as the H1n1 virus in China, essentially initiates a new pandemic response as our scientists and partners around the world work to characterize the virus, develop and distribute new diagnostic tests, and investigate transmission patterns and disease severity. Okay. Since the 2009 H1n1 pandemic, CDC has reviewed and updated tools for pandemic preparedness, including the Pandemic Influenza Preparedness and Response Framework, which can be used as a pandemic planning guide, the Influenza Risk Assessment Tool, which assesses potential pandemic risk posed by influenza viruses that currently circulate in animals, but not in humans. A strain is scored on 10 factors for the likelihood that it will change to infect people and for the potential severity if it does. The Pandemic Severity Assessment Framework guides public health officials to anticipate the severity of a pandemic once a novel virus is identified and is found to be spreading person to person in a sustained manner. Available measures of clinical severity and transmission are used to guide decisions about which actions public health authorities recommend. And community mitigation guidelines provide the latest scientific evidence available on the use of non-pharmaceutical interventions to slow the transmission of a pandemic virus. So what progress have we made? Due to global investments in pandemic preparedness, there is a global influenza surveillance and response system with mechanisms to quickly share laboratory and surveillance information. Laboratory capacity has shown exponential improvement in recent years. We can now sequence a full influenza virus genome in a single day, and there are greatly improved tests to detect novel influenza viruses, and these are shared with more than 140 labs around the world. There is personal protective equipment to prevent transmission, particularly in healthcare settings. There are vaccines available, and selected vaccines are stockpiled for pandemic use. Vaccine manufacturing capacity has expanded in the past decade, including development of new vaccine technologies. There are 3 recommended antiviral drugs to treat infection, and there are many antibiotics to treat secondary bacterial infections. There are mechanical ventilators and intensive care units to care for patients in respiratory failure. There's a One Health initiative to increase interaction and cooperation between human and animal health authorities. And we are now experienced in presenting pandemic information through a variety of media channels to support life-saving actions. While tremendous advances have been made, there is still much to be done to improve pandemic preparedness. Only about 1/3 of the 196 countries that signed on to the international health regulations in 2005 currently report having the ability to assess, detect, and respond to public health emergencies. To improve, we need to fill the surveillance gaps. There are geographic gaps in global surveillance, including parts of Africa and the Southern Hemisphere. We need better surveillance of influenza viruses circulating in birds and pigs. And the ability to share physical virus specimens needs to be improved. Better diagnostics are needed, including over-the-counter and point-of-care tests. Vaccines, as you've heard, must be more effective, more broadly immunogenic, and available more quickly. Global infrastructure to produce and distribute vaccines needs to be improved. Better personal protective equipment is needed, and needed in large supplies. Better, less costly influenza treatments are needed. And there are large parts of the world that don't have the medical infrastructure and equipment to treat severely ill patients, and they must be supported. And even in this country, we need creative approaches to manage the demand on healthcare. So in conclusion, much progress has been made, but we remain vulnerable to an extreme pandemic. Influenza viruses are constantly changing, requiring sustained efforts to anticipate, detect, and respond. The number of novel viruses detected is increasing, requiring ongoing laboratory and epidemiology work. And a weak link in global preparedness is a threat to all countries. So achieving global health security must remain a priority to lessen the threat of pandemics. Thank you.
Thank you, Dan. The next speaker is Dr. Ciro Ugarte from the PAHO WHO, the Pan American Health Organization, World Health Organization. He began his career in Peru, working in general practice in the highlands of Cusco. And in 1987, he was appointed as regional director and later deputy director general of the National Institute of Occupational Health. He served as the Director General of the National Defense and Disaster Relief Office in the Ministry of Health in Peru. Dr. Ugarte joined PAHO as a short-term consultant in Honduras, where he also serves as the United Nations Disaster Task Force Coordinator for this country. He presently serves as the Regional Advisor for Emergency Preparedness and Disaster Relief at PAHO here in Washington, D.C. Ciro.
Hello, how are you doing? Very good. I'm pleased to be here because I engaged very well with the previous presentation on how is the world prepared for the next pandemic. And the presentation that I will give you is regarding the international response to a potential pandemic. So one of the conclusions of the international response is that it should be, to improve the coordination of international response, they have to be complementary to the national capacity. So each nation who is able to early detect and share that information and begin the response, meanwhile the international support is coming, is crucial for that. So how the world is performing on that? It is related to the international health regulations capacity. But it was approved in 2005 and began into force in 2007. But you see that the countries are not there yet. Most of them have requested an extension to reach those capacities. And the last extension was provided in 2014. So in the Americas, for example, only 13 of the 35 countries have reached that level on a self-assessment aspect. So they say that they are there. But how are they performing in terms of those capacities? You see here how the countries have been performing one year to another. And you see, for example, the first year is 2011, and then we go to 2016 in each of these areas. And we see that the capacities are increasing in legislation, coordination, and national focal points, etc. Zoonotic events are coming above 90% now. And you see that the chemical capacity and radiological emergencies are also increasing. And for the first time, more than 60% of the countries are now able to reach those capacities. And then we see that the status of those capacities also in terms of which are the regions, of the sub-regions in the Americas that are better prepared. We see that the Caribbean region is still lagging a lot on that. So 12 out of 15, 80% of the countries have reported, and we see that in certain capacities like radiation emergencies or chemical events are very low. But we see also that Central and South America are very high in terms of most of the infectious diseases related capacities. And how are they doing in terms of their contact with PAHO and WHO? We test those contacts. And you see among the years that the contacts in the connectivity test by email, for example, is above 90% in the first 24 hours of that. And the connectivity test by telephone, in the next hour of that is more than 90%. So we do have the connectivity with most of the member states, and they are reporting to PAHO. And how are we doing on the points of entry? We're moving from the certified ports and airports, 2 rounds of consultation with state parties. State parties are the ones who signed the international health regulations. And we have draft procedures. The final report is not there yet. But we have, you see here, 64 ports in 31 of 35 states are certified. 78 airports, 22 ground crossings, and then we are moving around 500 authorized ports in 27 state parties in the region. So we are moving towards the points of entry. We are not there yet. We are moving towards that, and most of the countries now are eager to do that. In a couple of weeks, I'm going to Chile to do the third exercise in a row in terms of points of entry. And they are not only in terms of airports and ports, but also in terms of those type of ports that do have entries through tourism, for example, like Easter Islands and others. And these are the events that are being reported by who is reporting on that. You see the national focal points is the yellow, dark yellow, or maybe orange. And you see more or less 40% of the source in 2017 are coming from the national, so it's official. And it's official also through the government. But you see that there is a large amount of events that are not reported by the governments. So how can we say that they do have an outbreak if the government or the national focal point is not sharing that information? So we are seeing that in terms of also of what is the type of events that are reported. And most of them are infectious, but still there are some issues on food safety, animal health, and others, and these are the differences between all the years, how we're going through. This report that was being officially up to 13th of July this year. And how is this system or reporting going in other regions? We see here, for example, that the AMRO is dark blue, Euro, EMRO, CIARO, and WIPRO. We see the huge difference in the reporting in the Americas. Why? You know why? Because we work with the governments, with the countries, and we are convincing them, along with several partners in the region, that they do have to report. And they are reporting. So overwhelmingly, in 2016, for example, most of the reports come from the Americas. And it is not, also in comparison with all the other regions, we see that the AMRO region, and then AFRO, Euro, EMRO, CIARO, and Southeast Asia, and West Pacific region. So clearly, the Americas is overwhelmingly the best, let's say, prepared region in terms of alerting on the events. Is that is the capacity in place? Well, let's see what's happening in the surveillance. You see all the countries that are with surveillance and countries without surveillance. So we have few countries that are without surveillance. Well, the countries that are not reporting actively, okay? So it is, as we saw previously, it is the official reporting and unofficial reporting. And how are we doing in terms of reporting on biological data? And we see here that 75% or greater reporting in several countries, but the light blue is more than between 50 and 74%, and there are other countries, still important countries, that are reporting less than that, biological data. So what are the differences? For example, we are following also tracking how many samples are being tested or sent to CDC, for example, the WHO Collaborating Center for Pandemic Influenza. So in 2014, we had up to 6 shipments, 2 or more shipments, and you see in 2016. So the tendency is going forward. We are doing much more reporting on that. And this is the number of samples that are tested by the National Influenza Center. So you see the number of tests are in the tens of thousands, nearly 70,000 in 2016. Yes, we are moving on that. But is this enough? We do have tools, WHO surveillance tools. We do have PAHO surveillance tools that are also being applied on top of the WHO's tools. And we have the capacity to deal with pandemics. But once the pandemic influenza comes, we will most probably know, you and we, through the media. So it will be extremely difficult to to control the pandemic once it begins. It happened in the case of Mexico City. We had huge challenges to control that. And the biggest problem will be insecurity and economic impact rather than health impact. So it is a huge political thing. So what happened after the 2009 pandemic influenza? There were United Nations were important partners. Government missions coordinated by PAHO were useful, but also UN agencies not only reduced their participation, but they became victims. We have to provide support to the UN agencies in the affected country. And some government members, the Global Outbreak and Response Network, maintain their institutional objectives rather than the overall control of the epidemic. So we do have issues there, and we have an interagency work. We work a lot with all those partners and the Global Outbreak, but the problem is that each of those institutions have their own mandates, their own interests, and then when we come, the biggest challenge is the coordination. Why? Because everybody wants to coordinate, but nobody wants to be coordinated. So it's a difficult task to do that, and so we need to politically endorse the documents, ensure coordination among established organizations, but also establish operational coordination procedures. We are working on that. 24 countries have sent their delegates this week to PAHO to coordinate in this alert and response to pandemic influenza. So we need also, with those partners, time-consuming crisis meetings without operational impact. Yes, we have to unproductive duplication competition. We do have that. We see that even inside the countries. And in this emphasis on visibility rather than excellence. We want to be in the photo. And convenience rather than effectiveness, and ambitions not supported by available resources. So we dream a lot, we don't sleep enough. And the final goal, to enhance national and international capacity to respond, to strengthening and completing the local response capacity, and improving the quality of external assistance. Thank you so much.
Thank you very much, Ciro. Very, very enlightening. We will be taking some questions. I will start off a bit, and it's hard to see with the lights here, but I hope that you from the audience will have some questions to our colleagues. Dan, I wanted to start with you, and you've mentioned many of the key responses that would occur beyond just when an epidemic occurs, beyond just the vaccinations. One question I had is if you could compare what did happen or did not happen in 1918 compared to what you believe would happen now, and from everything from ventilation, from the antibiotics, but also talk about the capacity even here within the United States to be able to respond.
Yeah, so I had a list of a variety of capabilities that we have today that we didn't have in 1918. And a lot depends on how severe the virus is and how transmissible the virus is, obviously. There are limits to what, even in the United States, our healthcare capacity is and our ability to provide antiviral medications, ventilator, respiratory support, all those have their limits. So I don't have direct numbers, and perhaps, Dr. Berry, you do, on modeling today's therapeutic interventions and public health interventions on the population then. But it's clear, even with our more modern pandemics in the past few decades, that we have much greater capacity to respond, and we would expect to respond more effectively to a 1918-like virus. But we could have one more transmissible and more severe. So that's why all this work across the spectrum, including universal vaccine or better vaccines, are so critical.
Thank you. And to Ciro, one question I have is, even within the Americas, we see the disparity amongst many countries in Americas. Can you talk a little bit about the differences that you may see, let's say, in some of the more responsive countries, you don't have to name them, and the differences that may occur in terms of both preparedness, but in particular in response? And maybe you can use Mexico as one example, but what the question really is to try to get at the differences in the capabilities of various countries, even within the Americas, never mind in Africa or other areas that I'm more familiar with.
The most important aspect of the country's capacity to alert and to share information is that the national focal point of IHR, or the national officers, health officers that have to report that, they are empowered to do that. And most of the cases, they have to filter the sharing of the information through the political channels. And you know, immediately when it reaches that level, it is the economic impact that is facing. So even in pandemic influenza in 2009, we saw that many countries that did have the capacity to, let's say, detect, they were not reporting because the economic impact would be huge. And that's some of the aspects that do happen in the Americas. Most of them are able to detect, not necessarily the specifics of it, but they can report. And in some countries, we do have that delay. Not necessarily only the countries that we saw in the picture that they do not have a surveillance capacity, but most of them, they lag on that. Mexico showed, by example, that they were able to report almost immediately when they discovered that there was something new, different. And they declare emergency. The response happened almost immediately. They welcomed many partners. I was there coordinating WHO's response for the first 2 months. And we saw that the capacity was there. But some of the officers that were in charge of pandemic influenza were moved out of their offices a couple of weeks ago, or before that, because of the reorganization. And because of political reasons, they were not brought into that. It happened also in 2008 in the yellow fever outbreak in Paraguay. I had to convince the Minister of Health to appoint the person who knew more about yellow fever that was at the opposition. So those are the political and economic aspects are the ones who will make the difference, in my opinion. It is not, and security and safety, and not necessarily the health aspects.
Very interesting. Opening up for questions, please raise your hand. Yes, we have one at the back, please. They're coming to you right now, and please introduce yourself.
Hi, I'm Terry Monmany from Smithsonian Magazine. A question for Dr. Sozin, please, and that would be if you could comment on the impact, if any, of the current White House administration on the ability of the CDC to respond to future or near future influenza pandemic.
Sure. Pretty much everything I talked about, the type of work we're doing, continues to be supported. There are many potential changes coming in the future that I can't predict myself, much less a pandemic. I feel that the kind of work, the areas of work that we are working on continue today as they did 2, 3, 4 years ago. With the same sense of urgency that we have that this is really important work, and by hook or by crook, we're going to figure out how to keep doing it. So I can't speak to political changes which may come in future budgets. I just hope and pray that we get the resources we need to continue to do the work we do. And if those resources change, we'll figure out how to adjust and do the best we can with the resources we do have.
Are there any other questions from the audience before? John, do you have? Yeah, please.
Two questions. I'll name one of the countries that was slow to report, and that was Brazil. I know for a fact that there was a back channel feeding information from epidemiologists in Brazil to the White House during 2009. And the White House was telling the source, that they were getting information 2 weeks faster than from the government. But my question actually, and I want to applaud you for, you certainly did tell the truth. Really appreciate your presentation. My question is, it seemed to me that Mexico also told the truth and got punished for it internationally. And I'm wondering if, from your perspective, things have improved at all.
Thank you for those two questions, very important questions. Brazil, though, after that problem, requested PAHO to do an external evaluation of the H1n1 2009 response. And we found that Brazil recognized community transmission 12 weeks later than it actually happened. And it caused Brazil, the southern states of Brazil, to have the highest lethality of H1n1 2009 in the world. So they modified their procedures, and up to the last 3 or 4 years, they improved a lot on those things, okay? Yes, Mexico was punished, but Mexico was punished, Paraguay was punished, Haiti was punished, Peru, my country, was punished after cholera outbreak that we reported on time. It was the second day, and we were punished. What was the punishment? Punishment is economic punishment. Pandemic influenza in Mexico. Irrational, exactly, because of the fear. Fear causes all these decisions to be made in a fearless, in extremely fear-related decisions. Closing borders, stopping all the importations of products that are not related with that, stopping tourism and entertainment, etc. Just a relation. Mexico spent more or less $180 million to respond on the health response to pandemic influenza. The overall cost, just on the first wave of 2009 pandemic influenza in Mexico, was $9 billion. You make the math. And who was chairing, who was coordinating the response to H1n1? The Ministry of Health. It's nonsense. So the preparedness, it is multi-sectoral preparedness. It is the security sector, the tourism sector, the transportation sector, entertainment sector, other sectors that have to be there in order to respond. We had that on paper. But in reality, the National Emergency Management Officer in Mexico, sorry, I will say that because I was there, was not allowed to enter to the coordination meetings. I had to negotiate with the health officers to let her get in. And that was the FEMA-like director, the chief of FEMA-like. So we see those type of things, and then we see where the fear is coming from. So the thing is, yes, most of the countries are prepared, but not at the level of political willingness to control the economic impact of this. Ebola, for example, you see the health impact and you see the economic impact. It's overwhelmingly large. So we are not touching the proper buttons there in terms of preparedness.
Excellent, thank you. I will have one more question, but I want to make sure that, because we have a couple more minutes left. Any other questions from the audience? Okay, my one point is exactly what Ciro, what you were saying, is that the health response is a huge, but one component of a much broader, and we've seen this consistently. You mentioned Ebola, we've seen what's happened in polio, is the political response and the economic response are essential. And but the other thing, and John Barry mentioned this, is the community response. And although I know it's extremely different, but what we saw in Ebola, we learned that the community response was probably just as or more important than others. And Dan, you had mentioned that you have a community mitigation guidelines, the MMWR for CDC. So I'd like briefly, we have 2 minutes left, but starting with Dan and then Ciro, to talk a little bit about the community, either both your experiences, but also how you think you can address the community to make sure that they are supported in a decent response as opposed to just fear.
Well, I saw Jim Blumenstock here from the Association of State and Territorial Health Officers. CDC works domestically to provide assistance, support, guidance to the health officials who have the authority to do this work at the state and community level. These community mitigation guidance isn't the breadth of work that happens at a community level. These are the non-pharmaceutical interventions that could delay or forestall certain aspects of the pandemic, prevent some disease, and spread it out over time to lessen the burden on the healthcare system and the public health system. And we have more data because of the 2009 pandemic. So there is more confidence in these measures and a little bit more information as to when they might be most effectively applied to give guidance to those state and local health officials to take action at an appropriate time. I do believe very strongly in the message that John Barry gave us about communication and officials communicating. We know a lot more about effective communication in health crisis and working as best we can to get political leadership to follow those principles will be key here. And lastly, I just wanted to respond to the point that the health leadership kept out the rest of the emergency response leadership. In the United States, we've been working for the past 15 years to get public health a seat at the table. And it's been an important and challenging journey to get there. I don't see us ever having the lead in a national response of this nature, but having a voice and letting scientists be at the table with the political leadership has been very important.
Community participation is crucial, but the first thing to have the community participation is their trust in the authorities that are telling them what to do. And if they don't trust the health officers or the government in an everyday basis, why will they trust them in a crisis? So it is a very complicated aspect. So we have to build that. And yes, telling the truth is important, but telling the truth all the time, not just in times of emergencies, you know? So, those things happen, and also if we are able to convince persons from different perspectives telling the same message. And during the cholera outbreak in Peru, we managed to have one of the lowest lethality of cholera because we convinced the academia, but also the College of Surgeons and the media to help us. And we began first with 12 or 20 or 24, between 12 and 24 recommendations. And then we came up to 3 recommendations, knowing that. So doing risk communication will only work if we do crisis communication. So telling the people that we are taking care of them, but telling the truth. Not expanding that, not diminishing the risk. And that will build the community participation. The communities are not able to respond to all emergencies. That's a dream. That will not happen. That dream that may transform into a nightmare. No? So it is the crisis communication and also the trust in the governments that will make the difference.
Thank you. So you want authorities to tell the truth all the time. Utopia, that's a great dream. You are still a dreamer and you work with PAHO. That's wonderful. I want to thank Cyril and Dan very much for their very insightful comments today. And let's clap.
Hello, I am Tom Inglesby, and I am the director of the Center for Health Security at the Johns Hopkins Bloomberg School of Public Health. And our center's mission is to study epidemic risks and to work to try to diminish the consequences of those risks. And it is my pleasure to introduce our next speaker, Dr. Sally Phillips, who is the Deputy Assistant Secretary for Policy at the Office of the Assistant Secretary for Preparedness and Response at HHS. Sally is responsible for policy development, strategy, and overall coordination of activities that we're talking about today within that office, which is one of the most important offices of government, alongside CDC, NIH, FDA, and others in the federal family working on these issues. Before Sally was in this role, she worked at the Department of Homeland Security at the Agency for Health Quality and Research, and on the Hill prior to that for a number of years. And I think it's fair to say that if you're working on pandemic preparedness in Washington, you know Sally and Sally knows you. So we're very fortunate to have you, Sally. Come on up.
You can all relax, there are no PowerPoints, so you have a few moments of rest. Dr. Bob Kadlec is our Assistant Secretary for Preparedness and Response and was hoping to be here with you today, but he sends his regrets, and I'm delighted that he's not here because I am. So, but I did want to share a little bit of his view and his ideas, since many of you haven't had an opportunity yet to interact with Dr. Kadlec or to hear some of ASPR's perspectives and possible changes as we move into a new era. In this ever-changing threat landscape, Dr. Kadlec's view of preparedness and pandemic preparedness particularly articulates a position where strategy implementation and the evaluation of progress should be based on the threat landscape rather than a program base. And under Dr. Kadlec's leadership, when we say threats, we mean any threat to the health of the American people. These threats may be naturally occurring, infectious diseases, extreme weather, accidental, recent accidents that we've had in some of our biosafety incidents in labs, or deliberate, CBRN, cyber attacks on the healthcare system. We recognize that in order to mount an effective response, the systems we put in place must be able to adapt to whatever type threats that we're faced with. To achieve this, we develop nimble public health and healthcare response strategies that focus and hone in on federal resources and support to state, local, tribal, territorial stakeholders as they identify risks and develop capabilities to address the known and the emerging threats. Dr. Kadlec aims to do this through 4 key priority areas. First, to provide strong leadership, including clear policy direction, improved threat and situation awareness, and secure adequate resources. Second, to seek the creation of a national disaster healthcare system by better leveraging and augmenting existing programs such as the Hospital Preparedness Program and the National Disaster Medical System, NDMS, to create a more coherent, comprehensive, and capable system integrated into daily care delivery. Third, support the sustainment of robust and reliable public health security capabilities, including an improved ability to detect and diagnose infectious diseases and other threats, as well as the capability to rapidly dispense medical countermeasures in an emergency. And fourth, to cultivate an innovative medical countermeasures enterprise by capitalizing on advanced biotechnology and science to develop and maintain a robust stockpile of safe and efficacious vaccines, medicines, and supplies to respond to emerging disease outbreaks, pandemics, and chemical, biological, nuclear, and radiologic incident and attacks. Our mission within ASPR is to save lives, protect America from 21st century health security threats. In June of this year, HHS released an update on the pandemic influenza plan. The update was developed through a collaborative process with our partners at HHS, CDC, FDA, and NIH, and expands on concepts outlined in the original 2005 plan. Acknowledge the advances made in science and research, and other outlines for continued improvement across key domains, and you heard some of that from Dan. These areas cross surveillance, epidemiology laboratory activities, community mitigation measures, development of medical countermeasures, healthcare systems and infrastructure preparedness, domestic and international response policy. In 2017, the update highlights progress since the original plan. We've made progress in addressing many needs for pandemic preparedness and response, and we're better prepared now than we were in 2005. Specifically, HHS supported state and local partners in development of their own pandemic influenza plans. We've worked with partners to expand the definition of who can vaccinate and in what settings. For example, 10 years ago, you had to go to the doctor or to the hospital to be vaccinated for seasonal flu. Now you can go to your local pharmacy. With respect to system enhancements for vaccines, treatments, and diagnostics to allow for wider distribution of medical countermeasures, the ASPR's Biomedical Advanced Research Development Authority, BARDA, has been working with partners with HHS, DoD, and other federal agencies and has developed and licensed new cell-based recombinant adjuvanted vaccines for seasonal and pandemic influenza. It's important to note that BARDA was created to bridge the valley of death, with flexible, nimble authorities and multi-year funding to promote innovation and facilitate partnerships with cutting-edge expertise. Over the last decade, BARDA has successfully built in-house technical expertise, developed 34 FDA-licensed products, 14 products to the Strategic National Stockpile under Project BioShield are ready for emergency use, and significantly expanded pandemic influenza domestic vaccine production capability. We increased in the bulk domestic vaccine production capacity from 60 million to 600 million over the last decade, thanks to significant United States investments in both egg and cell-based influenza vaccine manufacturing infrastructure, as well as antigen-sparing adjuvants. BARDA has also accelerated the antibacterial product development. With respect to the healthcare systems preparedness, the ASPR's Hospital Preparedness Program in the past year released new guidance documents for its awareness and healthcare coalitions. The funding opportunity announcements for 2017 through 22 cooperative agreements was released and outlines program requirements for both HPP and in jointly with the CDC's Public Health Emergency Preparedness Program. HPP's healthcare preparedness response capabilities represent the ideal state of readiness for the nation's healthcare system. These streamlined capabilities build and improve upon HPP's capabilities, particularly incorporating a greater focus on healthcare. These new capabilities cement the critical role of healthcare coalitions during pandemics and other emergencies, focusing on operational healthcare coalitions for effective response. For example, to achieve the refined medical surge capability, healthcare organizations must be able to deliver timely and efficient care to patients when demand for healthcare systems exceeds available supply. The medical surge capability also requires healthcare organizations and coalitions to take specific steps towards enhancing their preparedness for infectious disease outbreaks that may overwhelm the healthcare system. The capabilities also emphasize the importance of planning for crisis standards of care, which may play an important role during pandemics when demand for healthcare exceeds availability. When the healthcare system planning is incredibly difficult, it's critical to have an inclusive planning process, including the health departments, hospitals, EMS, clinicians, legal, and experts, just to name a few. The National Ebola Training and Education Centers were created after action during the 2014 Ebola pandemic. ASPR and CDC partnered together to establish the National Ebola Training and Education Center, NETEC, through a joint cooperative agreement that began in 2015 and will end in 2020. The NETEC is a consortium of the 3 healthcare facilities that safely and successfully treated a confirmed patient with Ebola in the US during the 2014 outbreak. NETEC mission is to increase the competency of the healthcare and public health workforce, to improve the capability of healthcare facilities to deliver safe, efficient, and effective care to patients with Ebola and other special pathogens. Between 2015 and 2017, the NETEC has developed metrics to measure facility and healthcare worker readiness to care for patients with highly infectious diseases. They've trained over 3,000 participants in special pathogens readiness and completed over 30 peer assessment site and readiness assessments. Created a suite of educational resources related to exercises and training for the care of patients with Ebola and other special pathogens, and established a phone line for federal partners to provide emergency consultation with healthcare facilities requiring assistance with potential cases of infectious disease. And lastly, they launched the Specific Pathogens Research Network in 2016 to create a national platform for the study of special pathogens. 2018 marks the 100-year anniversary of the 1918 influenza pandemic. There's an increasing milestone, and it's important to recognize and celebrate the significant advancements made in preparedness since that time. However, key gaps and challenges remain in our preparedness. We will continue to develop new and better ways to prepare for, respond to, and recover from not only pandemic influenza outbreaks, but also outbreaks of other emerging infectious diseases and release of highly infectious agents, whether accidental or intentional. Thank you.
So, he's on? Perfect. Just have time for, I think, a couple of questions. And You talked a little bit about the healthcare program that ASPR is managing in the federal government. Could you say a little more about what the government, what did we all learn in the experience of Ebola when we tried to take care of highly contagious patients, because that's so relevant for the pandemic influenza preparedness?
I think in some ways it caught us a little off guard. We deal with infectious patients every day in hospitals. We have infection control nurses. We have systems in place to monitor and track infectious diseases within our hospital situations. But bringing something forward as unique as this put a challenge on to how is it transferable and what are the other levels of care related to infectious diseases when we don't really know the cause or it's something that we've never dealt with, has really put a challenge and sort of a wake-up call to go back and revisit. When I was a nurse in the hospitals many years ago, we had continuous education classes almost on a weekly basis of something or another. A lot of those programs had not been in place in hospitals where we were bringing people back together and reintegrating their knowledge base on certain things. And I think what Ebola did was to give us a little wake-up call that, you know, we needed to put an emphasis on infectious disease and not just the things we were used to doing and the most commonly occurring. The challenges of some of the donning and doffing and the special pathogens, and there was fear involved in the healthcare system, for the providers trying to get ready and to do the right job. It really placed a new challenge and a new lens, I think, on education and training for our staff.
Great. And for people who are unfamiliar with how hospitals are involved in preparedness programs, could you explain, is it a grant program, a requirement? How does the federal government interact with hospitals in America?
Yeah, the Healthcare Coalition program is the HPP funding that comes from ASPR. That informs and enhances the ability of communities to build coalitions amongst healthcare provider communities. In its original inception, it was a hospital preparedness program, and over the years, we recognized that preparedness is a community-based focus, so we need to draw in all the other members within that community, emergency medical services, long-term care, the primary care networks, trying to build a coalition of people in that community or in that region that when an incident like a pandemic comes up or another disease, you're going to have to pull in resources and share resources to meet the healthcare needs of that community. So the HPP program, in fact, rolls out to those healthcare coalitions around the country.
And is that related to the program that sends emergency healthcare workers to hurricanes and to responses? There's a disaster. How do they relate?
That's the National Disaster Medical System. That's a separate program that is short-term employees. They are physicians, nurses, healthcare administrators, pharmacists from all over the country who volunteer to be temporary employees with us during an event. The National Disaster Medical System, we have teams that are activated during a response, and they go in for a 2-week period of time, provide care when they are needed, and they do a rotating system. The last 3 hurricanes challenged our ability. Many of those, all the teams, I believe, were activated, and many of them did another tour, if not more, in order to meet the healthcare needs in a community. They really come in to supplement and support the medical care needs during those events.
Maybe one last question on medical countermeasure development.
Mm-hmm.
So we heard a little bit from the first, or a lot from the first panel about the work on influenza vaccine development. What's the role of BARDA within your office in terms of how does it relate to the NIH process, the FDA, CDC?
BARDA is the later term entry into this process. They take the work of NIH and FDA and roll that into the advanced research development, bringing it to final manufacturing. So in that last stage, they are a partner along the chain from the end-to-end strategy in medical countermeasure development and partnership. So NIH sort of starts the process, FDA does the regulatory part as we try to get them out into the field, and then BARDA takes it up towards the end. And that's not a fair justice to BARDA, trust me.
But well summarized. All right, well, thank you very much, Sally. I really appreciate it. Let me invite the next panel up to the stage. Thanks so much, Sally.
Sure.
Excellent. So I'm very happy to be moderating this panel on strengthening pandemic preparedness in the front lines. I'm here with two superb and very widely respected people to talk about these issues for a little bit. On my immediate right is Marissa Raphael, who's the Deputy Commissioner of the Office of Emergency Preparedness and Response at the New York City Department of Health and Hygiene. She directs the programs, operations, administrations, strategy for the department's emergency preparedness and response work, including oversight for public health emergencies related to the healthcare system. And so Marissa is basically responsible for directing pandemic preparedness for New York City, in a summary. You can tell me if I'm wrong about that, but I think that's a good summary. To her right is Jamie Yosef, who is the Program Officer for Biosecurity and Pandemic Preparedness at the Open Philanthropy Project, which is an organization dedicated to making grants in this area and many other important areas. She's been leading the biosecurity program for the past 18 months, where she's been giving grants around the country and the world to diminish pandemic risks and those from other biological threats. And prior to her work at Open Philanthropy, she worked at the Department of Defense and on the Global Health Security Agenda at HHS and with the Federation of American Scientists, among other institutions. So I'm going to turn to them in a moment with questions, but I'm just going to start with a couple of observations. The first, just to kind of place the pandemic in a local context, is just worth looking back at what happened during 1918 in Baltimore, where our institution is. In 1918, there were 600,000 residents of Baltimore. Over the course of 1 month, 1 in 4 people became ill with influenza. 2% of those people died. So in 1 month, more than 3,000 people in Baltimore died from influenza. Every sector of the workforce in the city was affected. Communications was impaired. Trade with other parts of the country was impaired. Ethnic groups were scapegoated. It was devastating to the healthcare system. Overall, it was a major, major event in the life of Baltimore. So it's tempting to think that today we would be able to escape that, but a model from our center in terms of particulars concluded that a pandemic of the scale of 1918 at its peak would require 7 times the number of ventilators than we have on hand in terms of the number who would require that kind of medical care. And then my last point, before we turn to questions, is that no matter how you slice it, how the people on the front lines respond to a pandemic will have enormous consequences. We have to talk about the global issues. We have to talk about the federal issues. They're so important. But we also have to focus on the state and local systems, the doctors and nurses, the public health agencies that are doing so much of the work to prepare our country. So with that, we have someone who's really been focusing so much on that to start our discussion. And what I want to ask Marissa about, maybe you could take us through the pandemic efforts at a high level in New York City. Just explain how they work. How is the city preparing overall for pandemic flu?
Sure. So I think it's worth starting by saying, based on, we conducted in the recent past health and public health hazard vulnerability analysis, and pandemic flu ranked number 2, only after coastal storm. This was sort of on the heels of Sandy. But I think this is to say that this is a threat that we take very seriously, and we feel certainty that this is something that we're going to see in our lifetime. I think the point was made earlier about the health department, or sort of health, taking the lead in pandemic flu planning, and that's definitely the case in New York City, but it is a collaborative effort. We as the health department can't respond alone. This is a citywide response, and so while we take the lead and drive the planning, it's very much in partnership with the fire department, the police department, emergency management, as well as the healthcare system, which is so critical. We do plan for both mild to moderate as well as to a severe scenario, and our goal is to really limit impact and spread. So we don't assume that we're going to prevent it from entering into New York City. It's really about how do we limit the spread. We break it down into 7 key objectives, everything from surveillance and epi to vaccine management, antiviral distribution, healthcare support, non-pharmaceutical interventions, mental health, and last but certainly not least, communication and outreach. I think the other key point I wanted to make is that it's very much a living document. So really learning from previous events, which again was mentioned earlier. We started writing the initial plan with federal funding in 2006, but a lot has changed since then. We learned a lot from H1n1, but we also have learned a lot from Ebola, from Legionnaires, from Zika. All of these responses really inform a lot of the all hazards capabilities that go into a pan-flu response. And we also did an exercise in 2013 that also informed our planning. And the final point I wanted to make on this question is just that this is very much dependent on CDC public health emergency preparedness funding, as well as ASPR HPP funding. Again, without this funding, we wouldn't have the dedicated resources to focus on this type of planning.
Great. We turn to Jamie now. You've spent the last 18 months or so, and time before that, kind of wandering the country and the world looking for the most impactful ways to prepare for pandemics and other biological risks. And so you've talked to people in universities, laboratories, governments. What's surprised you the most? What have you learned about that? And what do you think maybe is the least appreciated about the potential for impact for pandemics?
Sure, thank you, Tom. So not much surprises me in this space, except for one thing, and that is that we find ourselves in a cycle of panic and neglect. And that is not a phrase that I've developed. It's borrowed from other colleagues in the field. And what that means is that while there is an acute response in reaction to pandemics like H1n1 or Ebola, and that it's at the highest level of leadership attention at that time, as soon as the acute phase of the emergency passes, it doesn't continue to be a sustained priority at the highest levels of leadership. And so I think the thing that's surprising to me is how quickly that happened after the acute phase of the Ebola crisis phased away. We've seen a number of warning shots in recent years. We saw the 2009 H1n1 outbreak that infected more than 25% of the global population. We saw the 2014 Ebola outbreak, and now we're dealing with a Zika outbreak. And I would consider all of these warning shots, and I think it's really incumbent upon us at the federal level, in the US government and other governments to maintain sustained attention. But when I talk to my colleagues in the field, a number of them say that we are in the neglect stage of the panic and neglect cycle. It's surprising to me that we're finding ourselves in this place, given that this is not the first time that we've gone around this merry-go-round. We were also very focused on the biological threat after the 2001 anthrax attacks, and there was a lot of high-level attention in the US government to this risk and a lot of funding. But as time went by, attention diminished, it diminished as a priority, and funding diminished, and now we're repeating that. And so I find that to be very surprising, and I'm hoping that we can learn from these warning shots. In terms of what's least appreciated about impact, certainly it's productive to have a lot of conversations about the direct impact of the disease on public health. But it's also important to remember that there are going to be secondary and tertiary and higher order effects, especially if you're dealing with an extreme pandemic that's larger than what we've seen in recent years. It's going to strain our hospital systems. It might strain other systems like food and water supply, electric power. It could lead potentially to conflict depending on the situation. And I think that it would be useful to draw lessons from the past about how these secondary effects play out. What are the nodes, the critical vulnerabilities, and how can we really be resilient, not only to the disease itself, but also from a critical infrastructure perspective.
Great. Marissa, let me ask you just a couple of questions together, and you can just bundle them. So what would you consider at this point New York City's greatest challenges in pandemic preparedness? What's the hardest thing that the city has to deal with? And as part of that, I don't know if this is one of them, but in terms of plans to get medicines to people, should we be fortunate enough to have medicines available in a pandemic? How will that work? And what do you think are the things that are most likely to go wrong? And how do you deal with that?
Sure. So I think for us as New York City, first and foremost, it's the population size and density that really comes into play. I think also being a port of entry. So we anticipate that this is something that will hit us early and that it will have dramatic spread. And, relatedly, as one of the major strategies being social distancing, I think that's going to be very challenging, especially with a public that's so dependent on mass transit. I've seen statistics that 5 million people ride the subway every day. I think the other big challenge is really, and just getting back to the resource issue again, I mentioned FEP and HPP. You know, I don't know if people are aware, but the FEP award has been cut dramatically since its peak in 2005. It's been, at least for New York City, a 37% cut, and then on the HPP side, a 38% cut since its peak in 2004. And so I think this is very concerning to us because this is the funding that we really depend on to really get the planning done. But as someone mentions, it's not just about planning, it's training, it's exercises. And also, as I mentioned, it's not the health department alone, it's really bringing together our colleagues. And a lot of what we invest in is really in personnel to make sure that this happens. And so when the funding gets cut, that's what gets jeopardized, and that's very concerning to us. And then finally, in terms of a general challenge, something that we've been looking a lot at as an agency have been issues of equity and health disparities, something that you see day to day, but certainly that you see in emergencies as well. And so when you start talking about scarce resources, how will those resources be allocated when chunks of the population may be challenged in having sort of day-to-day access? And so that's something that we worry about. In terms of how we plan to get medication to the people, you know, it's a multi-pronged strategy. Certainly we have relationships with city agencies that have medical divisions so that we can take care of our first responders. That's a critical first step. Relationships with providers and mechanisms to get medication to providers, to schools. You know, during H1n1, we did a massive school-based vaccination, and we have a robust point of dispensing plan. In 2014, we did a no-notice exercise where we were able to open 30 pods in less than 8 hours, which we were very excited to see sort of the culmination of pretty much a decade of planning and to really show that we were able to carry it off. The other thing that we are very proud of is we've really built some robust relationships with pharmacies. We have many pharmacies in New York City, the majority of which are actually mom and pop, not the chain pharmacies. And so we've been working on getting contact information for all those pharmacies and really thinking through how we can utilize them, also not just in a pandemic, but in other scenarios as well. In terms of challenges, you know, it's very challenging to staff pods when it's a vaccination scenario because not everyone can vaccinate, so that limits our personnel. Also, we found during H1n1, maintenance of cold chain during large-scale vaccination can be challenging but not insurmountable. And then really this issue of how to maintain adequate supply levels when resources are scarce. And then, as was mentioned earlier, just concerns about trust of government and people doing what we need them to do. And as someone said it so eloquently, you know, you really need to have those relationships built in advance.
So Jamie, in your view, what do you think the preparedness community is doing well, and what do you think are the biggest unmet challenges with the organizations that you've been working with?
So I think the number one thing that I would point to in terms of where the pandemic preparedness community is doing well is the global health security agenda. So I imagine a number of people in the room are familiar with this. That it was an international initiative that was launched during the Obama administration and is continuing under this administration. It's really focused on reducing pandemic risks globally, whether they're naturally emerging, accidentally released, or the result of a deliberate attack. And there are a number of things that are exciting about the GHSA. One of them is that it was really a focused effort to develop a shared set of goals across countries and across different sectors to prevent, detect, and respond to these threats. And that a number of actionable steps were highlighted, and funding was committed by the U.S. government and other governments to take on those tasks. And the intention has always been for this to constitute measurable progress, where governments and performers can be held accountable for results. So, and then I think another aspect of it that's been very productive is that it recognized that the ability to detect infectious disease outbreaks and the ability to respond to them is largely the same, irrespective of whether it is a natural, deliberate, or accidentally caused outbreak. And as such, they brought together the public health community and the national security community to work together to identify shared needs and to build one system And so those are both really productive aspects of that initiative. It's heartening to see that at the recent high-level GHSA meeting in Kampala, there's been a renewed commitment to this initiative. And so the open question now is whether or not the resources will continue to be there in the next 5 years.
Great. Marissa, on the healthcare side, I want to just drill into that a little bit more. How do you think any city, but in particular New York City's healthcare system, could respond to an event of magnitude like a pandemic? What kind of bed and respiratory capacity do we have on hand for pandemics in New York City? Ventilators from national stockpile, would that be part of it? How would that work?
So I think, as is true in all the jurisdictions, our emergency support function 8, which is run out of our emergency management agency, is really the linchpin of all health and medical coordination. So that gets stood up in a pandemic flu scenario. We have been using our HPP funds, as was mentioned before, to really build up the preparedness of the healthcare system. The way we look at it in New York City, it's really the funds are used to bring all the sectors together to address system-wide gaps, build coalitions both within sectors as well as across sectors, and then also to provide some support to facilities. And so, for example, we work directly with nursing homes, we provide support to the primary care sector, and so pandemic flu is definitely one of the scenarios that we work with the various sectors on. I think it's worth noting that in 2013 we did an exercise to test medical surge and rapid discharge, and we were able to tested it with all 55 hospitals, and we were able to show that all the hospitals were able to discharge up to 1/3 of their hospitalized patients. Now that was for a mass casualty incident, but we feel that it has applicability to a pan flu scenario. You know, in terms of number of beds and ventilator capacity, you know, we have a total number of 22,000 licensed hospital beds in 57 hospitals. And as of right now, we have 2,000 bedside ventilators that could be used for adults and 1,000 that could be used for pediatric patients. A few other things I wanted to note: we do have an ongoing contingency contract to stand up a nurse triage line, which we think would be really important to decrease healthcare utilization for less severe flu cases. And also through our Ebola money that we received, we have been doing a lot of intensive work with the healthcare system on infection control, including doing mystery patient drills in every hospital where we bring in a faux patient and we document what the reaction is, and they have to do an after-action report, and we check to see if they've made changes. And just at a high level, we're finding that infection control practices could definitely be strengthened, especially around hand hygiene, and also that even when patients are given a mask, there's a delay in when those patients are getting a mask. And our bottom line is that infection control really needs to become more routinized with more testing of staff, given staff turnover, to really make sure that it's just part of the way that the hospital is doing their day-to-day business, and really to maintain vigilance.
Great. Jamie, in terms of the work that you're doing, can you give us a sense of the opportunities for improvement, either where you see greatest opportunity for foundations like yours, and maybe even focusing on technologies in particular? What kinds of technologies are worth investing in addition to the science that we've started to talk about today?
Sure. So I see, not just for open philanthropy investment, but just for the community as a whole, there are opportunities to get stronger in all three of the prevention, detection, and response areas. On prevention, in particular, because I'm thinking a lot about deliberate misuse risks, I think there's an opportunity to get stronger on governance of dual-use bioscience. We've made a lot of progress in recent years in terms of advancing those policies, but I think we have a long way to go, and there's a lot of fruitful work to be done there. On detection, we have an opportunity to improve our systems for early detection of outbreaks. In particular, the technology that is rapidly emerging that could be very useful is next generation sequencing technology. If there are innovative ways to integrate that both into a clinical setting to identify unanticipated outbreaks in clinical settings earlier, and also to potentially apply that technology in the environmental monitoring setting, that could be another way to detect outbreaks very early and enable us to get on top of the situation before it spreads. In terms of medical countermeasures, I think I think something we really need to think about is, we're not sure where the next pandemic is going to come from. It's very hard to anticipate that. And I think we should be prepared to be adaptable. And so the kind of technologies that I think are most useful in that space are ones that are very disease agnostic. So broad spectrum antivirals, not only against flu, but other potential viruses that could emerge, particularly directed at the host immune response as opposed to the virus itself. As well as platform technologies, that we heard about from some of the earlier speakers, that enable us to rapidly develop new medical countermeasures or new vaccines in response to novel pathogens that we hadn't anticipated. Those are all opportunities to get stronger.
Great. I think we have time for maybe one more question each. And what I'd like to ask you, Marissa, is how do you think other cities are doing? I mean, in the public health preparedness community, we always hear about New York City because it's such a high performer, almost a couple of standard deviations above other cities at times, or at least that's the word on the street. So what's your sense interacting with the rest of America? Do you think other cities are doing as well as you've described today, or do you think it's a harder challenge for them? And what do you think is the most important thing for the federal government to be doing for cities and states?
So I think I actually wasn't naturally fall into the emergency management realm. I've sort of I started sort of at the beginning of the FEP program and as it's grown, and something that I've learned along the way is that what's valuable about planning is the process, not the document. The document may lay on a shelf. You always hear that, the plan getting dusty on the shelf. Yes, you should have tools that people can easily reference, but it's really about the process. And I think something that we've really learned through Pan-Flu planning, there's a lot of policy issues that come up, many of which you can work out in advance, ideally, and not at the time. So yes, it does require resources, and so it has been challenging. There was dedicated Pan-Flu planning way back when, and oftentimes, as Jamie mentioned, sometimes with different scenarios, you sort of have a focus on a particular scenario, and then it goes away. The thing I think that's really important to take away is that it's really about building all hazards capabilities that are flexible, nimble. It's about building systems that you can leverage for many types of events. And that does require continued investment. You need to, for the capabilities that we have built, they have to be maintained with continued investment. For the gaps that we identify, that needs investment to then address those gaps. And that has become very challenging for other jurisdictions and New York City as well. I think we do have more resources than a lot of other places, and we do try to share with others whatever it is we develop, but I talk to many of my colleagues across the country, and they are really struggling to just deliver on the baseline capabilities. You asked what it is that we need from the federal government. I think just continuing to really try to preserve the FEP and HPP funding, which is so critical for this kind of work, is really sort of at the top of the list. I think the other thing I'll say is, sort of better defining the roles of different federal agencies in this type of scenario. This isn't going to be day-to-day business, so understanding what those roles are and communicating it to state and locals. We did something really interesting after Ebola that I thought was actually a best practice, which was we got our federal partners, our state partners, and our local partners all together in a room and talked about what had gone well, what could we improve, with a specific focus on communication and coordination. I think that's really important to do. And then the final point I'll make is that sometimes, in these types of scenarios, guidance is coming fast and furious, and to the extent that state and locals can be consulted, I think that will be really important. Again, it can be done in advance, but also at the time, because we found in Ebola, H1n1, some of the guidance that came out would be sort of not really in sync with urban settings, and it created problems for us, specifically around public communication.
Great. And Jamie, you started to talk about this a bit already, but beyond pandemic influenza, you also have an interest, your organization has an interest, you have a personal interest in preparing for the broader range of serious biological threats in the world. What else are you worried about? Just so people are kind of leave thinking a little bit, in addition to pandemic flu, what should we be thinking about?
Certainly. So in addition to pandemic flu, we think a lot about man-made pathogens, engineered pathogens that could emerge in the coming decades, where They could be engineered to be more transmissible, virulent, or resistant to medical countermeasures. That's something that we think about because we feel that that could pose a severe pandemic risk. And it's highly relevant to our interest in low probability, high consequence events that we're particularly concerned with.
Okay, great. Thank you both so much for being with us. Let me just... Really appreciate it. Okay. And think we'll leave these here with us.
Okay, good afternoon. My name is Sabrina Schultz, and I'm a curator of physical anthropology at the National Museum of Natural History, where you are, where we have the wonderful mission of understanding the natural world and the place of humans within it. One of the great privileges of being a scientist in this museum is our connection, our service to the public. At the Smithsonian, it's our mandate not only to increase knowledge, but to diffuse it. And so with our exhibits, for example, we reach millions of people a year. I am the lead curator on an exhibit, there it is, that serves a critical function of public communication about pandemic risks and threats. It's called Outbreak, Epidemics in a Connected World, and it opens in May next year. Outbreak places influenza and other zoonotic viruses, Ebola, Zika, Hanta, Nipah, MERS, SARS, and HIV in an ecological context. We present human health, animal health, and environmental health as one health, and show how pandemics can result from a failure to recognize and respect that connectedness. So we do this with stories that demonstrate the principles of One Health, where human impacts on animal health or environmental health can be linked to impacts on human health, such as in a virus spilling over from wildlife or livestock and causing an outbreak. We explain the human drivers, the activities that spread disease, such as global travel and trade, and how they can cause an outbreak anywhere and threaten the health of people everywhere. We show the effects of a pandemic on human health and society, and the kinds of efforts needed to fight back by science and activism and healthcare and policy. We illustrate the importance of the community in breaking the curve of an epidemic and the cultural factors that will always be a part of that effort. And last but not least, we explain to our visitors the fundamental role of research and vaccines in preparing us for the next pandemic. So, Outbreak is a new kind of exhibit for us, and that's because public health is a new space for us as a museum, a place for us to be. You know, it's a part of our work, you know, as stewards of natural history, as a curator of collections like myself, that is motivating our exhibits in most cases. And while it is true that our collections do have value for infectious disease research, as we show in the table in the back room, that's not the only strength that we're actually using in this situation, in this place. We have convening power at this museum, which I think is demonstrated by this event today, and which is also shown by the many free public events that are supporting the Outbreak exhibit throughout its 3-year run. And so we want to raise awareness. We want to motivate behavior change, and we want to catalyze conversations about pandemic risks in the public. And because pandemics are global, a global health threat, we are trying to convene a global audience outside the walls of this museum and outside this city. Outbreak will not only be a new subject for our exhibits in a way, but it will be a new model. And that's because we designed a second version of the exhibit that will be able to pop up in a community anywhere in the world, using free resources that we'll provide digitally, including a guide to develop educational programming and template files to customize exhibits, because that is the important part, of allowing communities that are vulnerable to epidemics, pandemic risks, to have those tools to communicate and reach their visitors, their audiences, their populations in ways that we can't, with the most effective messages in the most appropriate way. And so these are messages about epidemics in a connected world. Outbreak would not be possible without the generous support of so many partners. We've just been really, really fortunate. Our donor partners are listed here. Just a few of our content partners are shown in that photo, and some of our partners are here today. And in this room, I want to say thank you so much to them, and really to all the rest of you for the good work that you do, that we try to communicate will hopefully successfully bring to our audiences, and thank you also for your attention. So now I'm going to introduce our final speaker of this program, Dr. Ellen McKenzie. She is the Dean of the Johns Hopkins Bloomberg School of Public Health and a Bloomberg Distinguished Professor with joint appointments in the Department of Biostatistics and the School of Medicine's Departments of Emergency Medicine and Physical Medicine and Rehabilitation. In addition to hundreds of publications and numerous honors, she was named by the CDC as one of the 20 leaders and visionaries who have had a transformative effect on the field of violence and injury prevention in the past 20 years.
Well, thanks very much, Dr. Schultz. On behalf of the Bloomberg School of Public Health, I would like to, first of all, extend my thanks to our panelists and speakers and our collaborators, the Smithsonian Magazine and the National Museum of Natural History. I will confess that I got here a little bit early today, and I took the opportunity to wander around the museum and was reminded, I hadn't been here for a while, and I was reminded how wonderful a place it is, and it brought back a lot of great childhood memories and memories of taking my son here. And it sounds like, based on what you just described, you're just taking it to the next level, and it's fantastic. It's really wonderful to see. I would also like to thank our sponsors for this event, the Bill and Melinda Gates Foundation and the Wellcome Trust. And a special thanks to you all for being here in this room, and for those of you watching online over the internet. As we have heard today, public health scientists have made remarkable progress towards identifying and characterizing influenza virus strains that could potentially cause a pandemic. And these efforts can also help identify other emerging viruses that pose a pandemic threat that are still of great concern, as we've heard. Our methods of global and local surveillance and detection have also improved, as has our capacity to manufacture and distribute vaccines. Our speakers reminded us of many other advances, but also pointed to the disparities across countries and regions within countries in our ability to prepare, respond, and recover from a pandemic. But clearly, more is needed to safeguard the population against another catastrophic pandemic. We heard loud and clear from the very beginning that the push to develop a universal influenza vaccine that protects against a wide range of virus strains must be at the top of our priority list, especially given that the current seasonal vaccines have limited efficacy. But we also heard that we may need to go back to the very basics of our understanding the correlates of immunity if we are to get closer to that ultimate goal of creating a universal vaccine. We heard many other areas of concern: the need for more effective global surveillance in both human and animal populations, a decrease in the time to vaccine production, faster and more equitable vaccine distribution, more research on antiviral drugs, including new classes of drugs and perhaps cocktails of drugs, and the use of innovative and exciting new technologies for rapid detection, and finally, the improvement in capacity and readiness of our healthcare systems around the world to respond to a pandemic with a focus on an all-hazards approach. Ongoing continuous improvement of our local public health infrastructure with an emphasis on forging multi-sectoral links is also critical, as we heard, in our level of preparedness. We also heard, again, loud and clear, that effective communication is critical. Health officials at all levels need to communicate health threats to the community in a manner that can be understood and acted on in a reasonable way. And as John Barry admonishes, our officials must always tell the truth, all the time. And they must get out front and stay out front. So that's a broad summary of what we heard today. I thought I would like to end the symposium today as we began it, with some history, although I will not pretend to be as great a historian as John Barry is. But I would like to reflect on the ways that the influenza pandemic influenced the development of our own Johns Hopkins Bloomberg School of Public Health. As a new dean, I'm only 6 or 7 weeks into the job. I'm particularly interested in our history, and I would be remiss if I did not acknowledge the input from our own historian, Karen Thomas, in reminding me of this rich history, especially as it relates to pandemics. So in October of 1918, what was then known as the School of Hygiene and Public Health held its first classes just as the great influenza pandemic began to intensify. Founded by William Henry Welch and the Rockefeller Foundation, the school made the pandemic the urgent launch point for its work. Influenza and its worldwide aftermath jump-started the school's growth as a leading center of research and training in epidemic disease. Wade Hampton Frost, the first chair of the Department of Epidemiology at Johns Hopkins, was already a noted influenza expert when the pandemic hit. At that time, data were extremely difficult to collect, much less interpret. But as the head of the Public Health Service's Office of Field Investigation, Frost worked with colleagues to conduct house-to-house surveys of a representative sample of communities nationwide. These surveys revealed one of the defining characteristics of the 1918 outbreak that we heard about today, and that is that the highest mortality was among young adults under the age of 40. Frost then published a chronology of the pandemic spread from the US to Europe and Asia. And this chronology became the model for all subsequent efforts to track global pandemics. Today, Frost's methods are still used to predict and measure epidemics. Under Frost's influence, the school would pioneer the tactic of teaching students shoe leather epidemiology, walking from house to house, block by block, to confirm all cases of a disease in a particularly defined area. The pandemic became a primer for Johns Hopkins students. The school's leadership in fighting epidemics intensified after alumnus and former faculty member Alexander Langmuir founded the Epidemic Intelligence Service, or EIS, at the Centers for Disease Control in 1951. Many Bloomberg School graduates have gone on to become EIS officers, and many EIS officers in turn have since joined the faculty of the school. One of those EIS officers, D.A. Henderson, directed the WHO's successful campaign to eradicate smallpox. He then came to the school as its 8th dean. Henderson, like his mentor Alex Langmuir, was also prescient in his pioneer advocacy of biodefense and biosecurity preparedness, and went on to establish the Center for Health Security you heard about earlier, which is now approaching its 20th anniversary. Alfred Summer and Henry Mosley, two other notable EIS EIS officers were sent to assess the 1970 cyclone in tidal bore that decimated East Bengal, now part of Bangladesh, and they conducted the first epidemiologic survey following a national disaster. Their goal was to guide long-term relief and recovery planning. Their EIS experience as epidemic fighters was a springboard for outstanding achievements in research, training, and administration at the Bloomberg School. Dr. Sommer became our 9th dean, and Dr. Mosley chaired the Department of Population Dynamics for over 20 years. The school's experience in fighting influenza built the foundation for its rise to international prominence in vaccine development, evaluation, and policy. The faculty have and continue to work on advancing the issues in development, testing, and policy for vaccines against cholera, influenza, HPV, measles, malaria, HIV, dengue, as well as other devastating diseases. And they have fully established the power of micronutrients to prevent both nutritional deficiencies and infectious diseases. Using the public health tools of laboratory investigation, biostatistics, epidemiology, and policy, the school has emerged in the 21st century as a thought leader, a convener, and first-line collaborator for tackling epidemics. During our century of existence, we are proud to have broadened the scope of public health, strengthened its scientific evidence base, and trained a global network of public health leaders. If together in this room we are unrelenting in our pursuit of new knowledge and application of time-tested public health methods, and not neglect the lessons we have learned, we will one day, hopefully, measure death from infectious diseases as a 1 in a million occurrence. Again, let me extend my thanks to all of you for coming and to those of you who are joining us online. Let's continue the conversation on our social media channels, online at the Smithsonian Magazine Hub, via the school's Global Health Now website, and here at the reception to follow this event. Again, thanks so much for coming, and good evening.